Sexual dysfunction has multiple effects on couples. For one, for many men, when the erections are not functioning the way they expect, they actually move away towards the non-intimate touch, that non-sexual touch. And the partner can take that as something to suggest that the man's just not interested anymore. In all reality, it's that the man doesn't want to go down a road where things are going to fail, particularly something that they place importance on. So it's not that the partner is not desirable or there's been changes there. It's generally the insecurity for the man that's limiting any of that even non-sexual touch. Additionally, we see that for the partner, they don't want to try to initiate something that they know is going to lead to frustration for the man. Why try to lead down that road if it's just going to be frustrating and ultimately end up in an undesirable situation? So we see that it really creates a wedge. Sexual dysfunction creates a wedge between couples. Even in the best scenarios, even in the best marriages, we don't anticipate sexual dysfunction is going to destroy the marriage or the relationship, but it does have an impact. And it is something that some couples ultimately just need to have a discussion about, and couples may decide, hey, you know, it's really not that important to us, but at least everybody's on the same page. I think all in all, sexual dysfunction may disrupt the communication between the couple. And working on that, and for the patient to realize, hey, this is something that most of the time they can't control, that's underlying a medical problem. And for the partner to realize most of the time, it is not a desire issue or anything along those lines. It is, again, that medical problem really kind of opens up the conversation so couples can actually address this in a meaningful way that ultimately will lead to satisfaction for both partners. For some couples, and particularly men, there is a change in sexual desire over time. Some of that change may actually happen when men hit their mid-30s, in which case there's a change generally related to marriage, having children, taking on increased importance with work, where sexual desire may drop a little bit because their focus has changed a bit more to productivity. In other times, we'll see changes because of medications. Antidepressants are a classic example that will drop sexual desire. Men with low testosterone will have a lower desire. And we may see that sexual activity takes on less importance as couples age, just related to life factors. Factors like raising children, who's in the house at a particular time, did children come back to live with couples after college, things of that nature. I think the important part when we're trying to determine is the decreased desire normal or abnormal, does it create a problem in the relationship, or is it seen by the patient as abnormal? If a patient tells me that, hey, this is not the desire I expect based on everything going on, then it's certainly worth looking into. But some change in desire over time is not unusual and may fluctuate, and it may just follow some of the life circumstances. When we look at sexual dysfunction, it's incredibly important to have the partner's input as well. Sometimes the partner doesn't necessarily want to be totally involved, and that's okay. But for the vast majority of couples, the partner's input goes a long way. It's important because it takes two to tango. So having the partner's input can really help shape what's going to be the right treatment pathway. At times, it's as simple as helping the partner understand that this is a medical condition that has nothing to do with them. That it's not a desire issue. It's not an issue with being sexually attracted. It's purely the underlying medical aspect of it. Many times the partners just need to hear that no matter how attracted the guy was to the partner, it just wasn't going to happen because of the blood flow, because of diabetes, whatever it may be. Additionally, when we start looking at treatment options, looking at couples in particular, what does spontaneous mean? What fits into the lifestyle that they're looking for? We still have couples that want to have sex multiple times a day, and certain of our treatments don't make that very possible. So looking at each couple, understanding what the partner's desire is as well as the patient's desire really helps us shape what's going to be an ultimately good outcome. A partner can make a big difference in how the patient recovers from a sexual dysfunction. And sometimes that recovery means that things are just going to have to change a little bit, that we don't have a cure to go back and stop years of smoking and the narrowing of the blood vessels, but that we can still come to an outcome that is very satisfying for both the patient and the partner. I think the big things the partners can do is to not take it personally, to realize it's not them that's the problem, it's the underlying disease. To encourage the patient to get out, seek treatment, and to be open to considering different options that are out there. Also, to have an open dialogue between the patient and the partner goes a long way in understanding what's going to work in this scenario, what's going to be pleasing, what's going to make both partners happy. I think for most couples and most partners, they need to look at this as a physical problem. Erectile dysfunction is a physical problem until shown otherwise. It is something that psychologically there is a role that's going to be played, and no man wants to go through something where they expect to fail, particularly if they put importance on that process as well as importance with that person. So yes, there's going to be a psychological component, but the vast majority of them we know are going to be 90 to 95% plus are going to have an underlying physical component. With that said, I think that's where we really need to focus. For a partner, keep in mind that men who have erectile dysfunction tend to have a higher likelihood of heart attack or stroke over the next 5 to 7 years. And so it's not just treating the erectile dysfunction where we're making a difference for patients. It's that we can then try to look at the underlying causes. How does that then play out over the entire health of the body? And what else do we need to change to keep the man as healthy and happy as possible? Yes, treatment options do change depending on what the underlying cause is. I think the best place you can see this is in men with diabetes. So for men with diabetes, unfortunately, even with really good control, they tend to actually have worse erections at an earlier age than men without diabetes. Now, with that in mind, don't let the diabetes go, because men who have poor control really have worsening erections much quicker than those men with good or decent control. What happens though is for many men with diabetes, they'll initially start with using medications, tadalafil, sildenafil, Viagra, Cialis, Stendra, Levitra. The oral pills will often work initially. Unless their blood sugars at that time are in the 250 plus type range, most of the time those medications will initially start to work. However, over time, diabetes will affect the nerves that go down that kickstart the process. Once those nerves are affected and the process is not being kick-started, well, the pills no longer function. Think of the pills as a megaphone. If there's nothing to actually start the process, the pills can't amplify that result. So what we see is that over time, the pills stop to work. And now all of a sudden we have to change our course and we want to look at a different process. And if we go to something like the Trimix or Edex injections, the injections are a small sub-Q, tiny needle that men hardly feel, but it bypasses the nerves. So when that medication goes in, even for men with diabetes, early on, they'll initially have a very strong response to that medication, and it can work quite well. Men can have good quality erections. With time, however, we may see the underlying process worsen. And so if blood vessels start to narrow, if there's smoking involved where the blood vessels slowly, progressively narrow over time, if there's increased cholesterol, increased blood pressure, which starts to narrow those blood vessels, ultimately we will see that the blood flow in may become problematic. On the flip side, things like prostate cancer surgery may damage the nerves right up front. However, if over time those nerves recover and we have good blood flow coming in, if nothing's been done treatment-wise, we can end up in a situation of what's called venous leak. With venous leak, we can get blood coming in. However, there's been structural changes in the penis so that now blood flows out too quickly. So even though the blood coming in is adequate, the veins are not shut down. They drain the penis, the blood coming into the penis too quickly, and patients never get a full erection. So depending on what the underlying cause was, will very much dictate which way we need to go treatment-wise and what ultimately might be the best solution for patients in the long run. For patients undergoing penile implant surgery, in a lot of cases, they have not been having sexual activity routinely, at least not for some time. There are exceptions to that, but for many of the patients, there has been a period of no sexual activity. For those men, when things work right off the bat, there is usually an uptick in the desire to have sexual activity. The interesting part is that usually actually kind of settles back to what most couples will consider normal, and things will get back to where couples had in the past when everything was functioning the way it was supposed to be. So just having the penile implant does not make it so men are going to want to have sex all the time. It certainly does not make it so men are going to go seek sex all the time. In fact, I think for a lot of men, it helps their confidence. It helps them feel like things are a little bit more complete. And it's just the fact that they could have sexual activity if the opportunity arises that really helps them feel like, okay, things are where they need to be. Men with sexual dysfunction in general, and particularly with erectile dysfunction, tend to have issues related to affection, even if it's non-sexual in nature. And that may be something as simple as less hugs, less smacks on the behind, less even just hand holding or touch in that regard. And it's because while those things are not necessarily sexual, they are things that men typically will then associate with intimacy. And if that intimacy is impaired on the back end, meaning that they're going to have trouble with erections, they may actually forego some of that affection early on. Now, some men this has almost no impact on, and they will go and find other ways to provide that affection. But partners should be aware that this does, for many men, change how they view things. And although it's not the most important part of a relationship, it hopefully wouldn't be, it is a part of a relationship and does at times create a barrier between the partners. For most partners, they will say it does feel the same when they have sex following implantation of a penile prosthetic. In fact, some of the men who have gone through penile prosthetics and do not have a set partner will come back and tell me that their partners never know unless they actually point it out to them. So we anticipate that sexual activity will actually have very much a similar feel. There are times where, as men age, the male partner may have trouble with erections and the female partner in some scenarios may actually have trouble with vaginal dryness or narrowing as well. There are times in those situations where a penile implant may not even be fully inflated. It may actually provide a better sexual satisfaction for both the patient and the partner without causing pain in scenarios like that. So yes, we anticipate that following penile implantation, that when patients and their partners have sexual activity, that it feels normal. As you can imagine, discussing intimacy issues that couples have gone through can be a pretty nerve-wracking aspect, particularly with somebody that you don't know or have a developed relationship. With that said, we do have patients and their partners that are willing to talk to couples of what worked for them. How did they get through this process? What was important? We also have sexual therapists that are available to discuss things. And I think what we find is that the more patients and partners start to interact with others and ask real, honest questions, the more people are actually open about it and share their experience, what worked for them, and what may have actually changed, whether it's from prostate cancer surgery, whether it's from prostate cancer radiation. What are the changes long-term that were different, that were unanticipated, and how were those dealt with? So yes, there are resources that are out there for patients and couples. Be sure to ask about them if that's important. We want to make sure that no stone's left unturned, that patients have all the information they need, and we really be able to tailor treatment specific for each couple.